Okay, drugs affecting the endocrine system. This is the other piece of your audio review, well, one of the many pieces actually, chapter 21. Okay, so we've got, everybody knows what their endocrine system is: hypothalamic and pituitary hormones, exocrine, pancreatic, your adrenal system, thyroid, okay, your pancreas with your diabetic medications here. All right. So let me see if I can find where we are here. This is just some basic things. Hormone regulation, bone formation. This is something you might want to keep in the back of your mind. PTH is calcium and phosphorus. Growth formations is estrogens, androgens, testosterone, the growth hormone. Your metabolic rate control, TSH, and your thyroid. Your carbohydrate metabolism is insulin and glucagon. And blood pressure is cortisol, aldosterone, and ADH. Okay? All right, this is where we're going to start. Your biphosphonates, used to treat osteoporosis and Paget's disease in both men and women. So what loses the most bone in osteoporosis or Paget's disease? The femoral neck. That is something you definitely need to know. Okay, so then you always have the your Fosamax and all these other ones. Actinol and Fosamax are the ones that I see most. You have one weekly, you have one monthly. Pharmacodynamics, this is how they treat and prevent. They inhibit osteoclastic activity and increase bone density. So they actually has to do with phosphorus and laying down bones. So this, you need to know the definition and how they treat osteoporosis. And you do see some definite reversal, but those drugs are not without side effects. So biphosphonates, you'll see some change in 3 to 6 weeks, peak at 3 to 6 months, half-life of 10 years. Scary. There is no metabolism. You excrete it in your urine, your feces. That's the unabsorbed drug. All right. The drug interactions: diarrhea, constipation, gas, hypocalcemia, hypophosphatemia, abdominal pain, dyspepsia. Sounds like you just want to go out and take an atrial fib. That's kind of the scariest one. Who takes this drug? All your elders, and half your elders have atrial fib. Okay. Drug and food interactions. Okay. Zantac doubles the rate of Fosamax's bioavailability, calcium supplements, and antacids. So you have to be careful what you're giving with any of those drugs. I think they're pretty careful about these, and they have strict instructions. Okay, so you're going to watch for your high-risk patients with your biphosphonates: white, Asians, history of eating disorders. Those are the people that are going to have osteoporosis. And then you're going to correct any pre-existing vitamin D deficiency or hypocalcemia prior to initiating biophosphonate therapy. Okay, once again, I'm in a different world now, and we don't really prescribe these unless we absolutely have to, but most of our patients where I'm at now have vitamin D levels close to 100. That's pretty unheard of, seeing that when they join our practice, they're about between 17 and 25. So vitamin D is not really, it's not really a vitamin, it's a hormone, and it's not just good for osteoporosis. It kind of affects all body systems. So don't be one of those practitioners that never ever checks a vitamin D level on your patient. Let's talk about a vitamin D level. If you have somebody who comes in with a 25, they need vitamin D3 plus some K2, 10,000 international units every day. And you're going to recheck a level in 3 to 4 months. That's not on the exam, that's real life what can be done. That's a scary number for a lot of people. Somebody that's even got a vitamin D level of 50 could definitely take 5,000 units safely daily, forever and ever and ever. All right. I don't think you have anything on human growth factor. Nope, doesn't look like it. Okay, pancreatic enzymes. These are used in cystic fibrosis. A lot of times you'll even see these in the peds unit where you're crushing up pills and throwing them down G-tubes sometimes. So they're for pancreatitis and cystic fibrosis mostly. Not a lot of reasons to give those. And pretty much you know the adverse drug reactions of the pancreatic enzymes as well. Okay, when you're dosing the pancreatic enzymes, there's three things in them, right? There's the lipase, the amylase, and the protease in them. How are they dosed? Each drug is specified in lipase. So actual dosing is the lipase dose. That's how they're dosed. Amylase and amylase, it says drugs are prescribed in units of lipase. Yes, always dosed in lipase, even though they have amylase, lipase, and protease in them. All right. And that's the take-home. Okay, diabetes. Type 1 results from destruction of beta cells. It's usually genetic. You have to remember that. 80 to 90% of type 1s have autoantibodies to 2-tyrosine phosphates. And those 2 autoantibodies actually you're genetically predisposed to. Type 2, complex disorder, which involves suboptimal response to insulin-sensitive tissues in the liver. Both type 1 and 2 can be treated with insulin. Insulin acts by increasing peripheral glucose uptake by skeletal muscle and fat. So since it's there, I think you need to know it. Type 1's very, very sad. You can have little kids have it, obviously. In the neonatal world, I saw my first ever neonatal diabetes, and it was a fluke how we found it. It was really kind of surprising. And that little guy got an insulin pump at 6 months of age. So type 1s are definitely insulin dependent. Let's talk about type 2. Why is type 2 so complex? In my heart of hearts, I believe we always cause type 2. We're our own worst enemies. We have the metabolic syndrome. There's not very many people who are doing everything right that get type 2 diabetes. Okay. All right. Newer premixed insulins are more effective at lowering the hemoglobin A1C and postprandial glucose levels in long-acting insulins. So your long-acting are like Lantus and Levemir. Lantus and Levemir are both really pretty expensive. In the nursing home when I worked there, I used to like Lantus because there is no peak, and if there is little. So you can give some pretty hefty doses, but you don't have any immediate hypoglycemia. So if you increase the dose, what you're doing is you give the nighttime dose first, and then you're checking some morning sugars. You want your morning sugars to be close, not under 100 when you're giving Lantus, and that's kind of how you dose it. It can be given AM, PM, it can be given BID. Take-home point here is no more of anything. Now this is clinical, this is not on a test. No more than 100 units of any insulin, like say they're on several insulins all together in a day. So you have to kind of be careful. But newer premixed insulins are more effective at lowering hemoglobin A1C, all right, than the long-acting. All right. Okay. Adverse drug reactions, of course, of any insulin or anti-diabetic, hypoglycemia, diabetic ketoacidosis, alcohol can increase hypoglycemia, can also raise your blood sugar though too. Drug interactions are with beta blockers. It kind of makes the blood sugar unstable. It increases insulin resistance, and this is what beta blockers do. It increases insulin resistance and it masks the hypoglycemic effects, symptoms, sorry. And I just went too far. Hang on here. Whoops, sorry. All right. Thyroids. All right. Goes right into thyroid. No, it doesn't. Here's some insulin. All right, non-selective beta blockers and alcohol, once again, mask the symptoms of altered glucose levels, which can be dangerous. And this is more pancreatic hormones, and back to more insulin. Okay, so what do you want to do for, it looks like we've got like a pregnant woman here. We got gestational diabetes, lifestyle management, low insulin, and exercising. Carbohydrate needs to be increased. Okay, now I know what it is. All right, it has nothing to do with that. If you have a patient who is on insulin and say he's a runner, what are you going to tell him to do? You're going to tell him that while he's exercising, he needs to increase. He needs to go eat a bowl of spaghetti first. He needs to increase his carbs. Patient education, a goal of an A1C is less than 7. I think that's pushing it. I think we need to have goals of less than 7. 5.6 would be a nice A1C. Under 6 would be great. And here's all your oral diabetics. So this is for type 2 who have insulin resistance. Sulfurinuria. You've got your metformins, of course. So we know that type 2 diabetes is excessive production of glucose by the liver. So what's the drug of choice? Metformin, metformin, metformin. So once again, another big band-aid and not fix the problem. So metformin improves hepatic response to elevated blood glucose and decreases glucose production and decreases GI absorption. Before starting metformin, a creatinine level has to be done for kidney to see what the kidney function is. Almost everyone that's got type 2 they all start out on metformin. Side effect of metformin is diarrhea. Sulfonylureas is the next choice, or the next add-on drug. This was definitely a board question too. You started out with metformin, your patient wasn't controlled, what were you going to give next? And it was sulfonylureas. Just so you know. Alright, so that's your glipizide. Okay. Definitely read through all this stuff, but you know the red is what you guys have to know for our exam. Alright. Sulfonylureas too, just take a point. If your patient's allergic to sulfa, they can't have this drug either. Pharmacy will not fill it. Alright. Not going to go any farther than this. I want to back up here a second. There's your metformins again. Metformin cannot be given in pregnancy either, by the way. Oh, let's talk about metformin too. Another thing too, if you have a patient who you're doing like a pre-op on, they'll come into your primary care for clearance. You have to educate them to stop the metformin before they go into the hospital, or for a CT scan, due to increased risk of lactic acidosis. Gosh, there's really not much on here, which is kind of crazy. Here's some of the new drugs. The alpha glucosidase inhibitors. These are your expensive ones. Carbos, Precos, Glycet. They're not going to ask any question about these. Gosh, I'm really surprised that. Okay, Actos is another one too. Doesn't work really super well on a lot of people, so it's an add-on drug. I've not had much luck with anybody I've had on it. You start out at 15 milligrams once a day and you go up to 45. I've not had a lot of luck with it at all. All right, sorry we're just scrolling, but I'm kind of trying to figure out what we need to know here. Aha. Okay. Gliptins. Gliptins work on the incretin system, which is indirectly increases your insulin production. So make sure you know pretty much that word for word, because you might see that somewhere. Januvia, another new drug, big pancreatic cancer risk with it. Okay, precautions. Must need to know all the precautions. It's all once daily. Okay. Byetta, glucagon, like peptide 1 agonist, promotes insulin release from pancreatic beta cells. And your drug interactions. It increases your INR. It's administered with warfarin. There's a drug interaction with digoxin and lovastatin. So remember, your diabetics usually get lisinopril, their diabetic metformin, lisinopril, and a statin. So be careful what you're giving your diabetics. Make sure it's not necessarily lovastatin. All right, I think that's it from what I remember, and I'll just go over a couple things here. Thyroid again. I think these slides must be in other places because I can't believe that there is not too much you need to know. Okay, levothyroxine. All right, so you have for patients older than 50 with or without cardiovascular disease or long-standing hypothyroidism should be monitored for cardiac angina. Why is that? Because they go into AFib. Okay. Okay, so here's your other antithyroid. This is for hyperthyroid. You have your PTU, and that's your drug of choice. And you need to know your adverse drug reaction for the antithyroid agents. Where did it go? Okay. Let's back up. Fatal agranulocytosis. And patient education. Should be taught to report fever, sore throat with any of these medications because it can be a fatal event. That's with your PTU. And I'm going to stop this now, and then I'm going to pick up the thyroid stuff in a different place.